All right. Well, good morning, everyone. We are so thrilled to reinstate the Dementia Conference after what feels like such a long time of COVID-related delays. Just a couple housekeeping pieces. There is a bathroom just outside of these doors in case anybody is interested. And of course, you're welcome to the refreshments throughout the duration of the conference. In addition, please take this time to make sure your phones are silenced or turned off. We don't want those going off during the presentation. If there are any questions, Dr. Tiller has reserved some time at the end of her presentation, so please make sure to hold your questions until the end. I wanted to also take this time to thank all the efforts that went into making this day possible. We are also appreciative for all the vendors that are here and our keynote speaker. Okay, can you hear me now? Thank you. I appreciate it. You should have found a presentation packet in each of your seats, and that will be for you to use, keep, and write on, and use for future viewing. I know a couple people have mentioned that if there are extras, they would like to take some home. That's perfectly okay. Gives me a really short window of time. Okay. All right. Thank you for bearing with us. So as I was saying, come see me afterwards if you would like another copy and there aren't any left over on the seats, and I'll be happy to get one to you. As we know, data on dementia is ever changing and ever growing. It's important for us to stay informed on this topic. Today, we're able to share with you someone who has devoted much of her career and passion with older adults, caregivers, and dementia. Dr. Tiller is an assistant professor of medicine in the Division of Geriatrics at UNC Chapel Hill and is part of the Outreach Recruitment and Engagement Corps of the Duke UNC Alzheimer's Disease Research Center. She obtained her medical degree from Duke University in 2014 and went on to complete her internal medicine residency training at UNC Chapel Hill in 2017. She's worked as an internist in a rural community health clinic before returning to UNC, where she completed a fellowship in geriatric medicine in 2020. Her passion is continuity of care for her medically complex older adults and supporting caregivers. Without further ado, I will pass the floor to Dr. Tiller.
Good morning, everyone. Before I get started, I also wanted to introduce my colleague, Latorius Adams, who is here today. She is a research specialist in the Department of Neurology and does work with me in the Outreach Recruitment and Engagement Corps with the Duke UNC ADRC. So we will both be available afterwards to talk to. And we'll take questions afterwards. When I complete the presentation, I will repeat your question and answer it. So an overview of my talk today, I think it's really important to talk about healthy brain aging. I get a lot of questions about that from my patients in our geriatric specialty clinic. And then from there, I'll do an overview of cognitive impairment, so mild cognitive impairment, which you may hear a lot about, and different forms of dementia, with a focus today being on Alzheimer's disease, a type of dementia. And we'll spend some time talking about prevention and treatments, and the one that you've heard about probably a lot in the media recently, aducanumab or Aduhelm, which is a controversial medication that's now FDA approved. So we'll spend time talking about that medication. And then from there, I do want to introduce the work that we're doing with the Duke UNC Alzheimer's Disease Research Center, and also talk about the North Carolina Registry for Brain Health, and we'll have information and pamphlets and even a newsletter that we do on a quarterly basis available for if you have would like to learn more. So let's start with talking about cognition. What does cognition mean? So there's multiple cognitive domains. It's actually very complex, but when my patients come to me with a cognitive concern, primarily it's a memory concern. My memory's changing. Well, there's a whole bunch of other cognitive domains that I like to assess for in our clinic and that are important for brain health. Language, so memory and language are actually quite complex cognitive domains. We'll talk about that in our next slide. But attention and concentration are important domains, and then reasoning and problem solving, and kind of overlapping with the reasoning and problem solving is executive function, how you plan and execute actions, and get goals done, stated goals done during the day. Visual spatial perception, what this means is how you see objects in space and how they relate to each other. For instance, if I asked you to copy a three-dimensional object like a cube, or you can get some information from some other cognitive tests you can do, the clock draw you may have heard about or done. This can give you some information about visual spatial perception. And then processing speed is actually an important cognitive domain, and we'll talk about that in the next slide. So what's normal? What's healthy cognitive aging, right? There's a great article I read. It was actually in 2013. I think it's in the reference slide if you have the printout today. And it talks about healthy brain aging and what happens to your brain as you age. There are changes that occur. And I get a lot of people that come to me and say, you know what, doc? Yeah, my memory has changed, but I think this is normal. Is it normal or is it not? And so what we know from prior research is that vocabulary, which is within the language domain, and also your general knowledge, practical knowledge, overall over your lifespan should remain steady. The general knowledge is actually a type of memory. It's called semantic memory. And these are things that you learn over your lifetime, right? This is knowledge, and these domains are things that you accumulate from your life experiences, and these remain stable over time. But what we've learned is that there are some cognitive changes with normal, healthy aging. You can see memory changes. You can see some more difficulty with problem solving and reasoning, that kind of executive function that I talked about earlier, and that your processing speed declines. I think importantly to note, language and memory are very complex cognitive domains. Some areas of language may start to decline. For instance, verbal fluency. What do I mean when I say verbal fluency? But if I asked you, let's say in my clinic, I said, I want you to name all the words that you can think of that begin with a certain letter in a minute. That may decline some over time, and that may be more related to processing speed, possibly. Some forms of memory also remain more stable with aging. For instance, procedural memory, so tying a shoe, riding a bicycle. You may not have ridden a bike in many, many years, but you're unlikely to forget how to ride a bicycle. Or remembering the words to sing a song, Happy Birthday, right? These are types of memory that you learned with life experiences and remain stable, okay? So let's go from there and talk about transition. So I think key point before we talk about mild cognitive impairment is healthy brain aging is not going to impact your day-to-day functioning, right? This gets a little complex because some individuals may not have cognitive impairment or dementia, and I might start to tell them, I think it's time to retire from driving, but that may be more related to maybe underlying medical health or processing speed that is slowing with time. So please don't get upset with your doctor if they tell you not to drive. So let's transition to talk about mild cognitive impairment. So I see this a lot in my clinic. This is where one domain or maybe a couple domains in cognitive health starts to have some deficits that is not just attributed to normal brain aging. And the key point is that it does not significantly affect day-to-day function and doing your day-to-day activities. This is considered a risk factor for developing dementia. Around 30% of my patients who I diagnose with mild cognitive impairment down the road over the next couple years progress to develop a neurodegenerative process, a type of dementia. And the most common type of mild cognitive impairment I see is mild cognitive impairment with the primary deficit being in memory domain. And that is a known risk factor for developing Alzheimer's disease. When someone is diagnosed with mild cognitive impairment in my clinic, I like to assess for a bunch of other things that are going on that could be contributing to some cognitive changes, right? So mood, anxiety, depression, maybe there's some sleep disorder going on, maybe there's medications that my patient's on that is causing some brain fogginess and difficulty with concentration and attention. Assess for alcohol use, et cetera. And oftentimes I do some basic labs, make sure the thyroid's working okay. I might check a vitamin B12 level, and I'm doing a full geriatric assessment in assessing for, are there things that we can do to help improve cognitive function, right? And I focus a lot on talking to people about their diet, a healthy diet, and exercise, and kind of thinking about holistically the brain and the body and what we can do. And I follow these individuals on a yearly basis for cognitive testing. So let's transition from there and talk about what is dementia? What does it mean? How do you define it? So dementia, to me, I define as a progressive decline in multiple domains of cognition that affect day-to-day function. So there is impairment in function. So typically, I see individuals who are having more difficulty managing their medications independently. I may pick up on it. I had a patient who was not remembering to refill prescriptions and take medications, and the blood pressure had been controlled for years, and then now blood pressure was not well controlled, and that was a clue to me that the day-to-day function was impaired. Driving is often very early on affected, and managing complex finances, et cetera. So dementia impairs your ability to live independently. I think another key point is I get a lot of questions from my patients in clinic. Is this Alzheimer's disease or is this dementia? And I think the key point there is Alzheimer's disease is a subtype of dementia, right? So there's a lot of different types. So Alzheimer's disease we think about is about 60 to 70% of the folks who end up being diagnosed with dementia have Alzheimer's disease. So it's the most common type. Vascular dementia is about 10 to 20% of individuals. And there's often an overlap. I think a lot of individuals end up having a mixed picture of Alzheimer's disease and vascular dementia. And there's a whole bunch of other types of neurodegenerative processes, right? I'm using neurodegenerative as another terminology for dementia. So Lewy body dementia is another one you may have heard of. There's a bunch of different types of frontotemporal dementia. For instance, primary progressive aphasia is very rare, but I've seen that in my clinic as well. And then you can develop dementia with Parkinson's disease, right? Early on, you're going to get the motor deficits and complaints, and later on, you can get mild cognitive impairment or a dementia picture. So I'm just going to give a brief little background because this is going to help transition a little bit later into the talk when we talk about treatments. So Alzheimer's disease is the most common type, and memory impairment is that most common initial symptom. So, right, when I diagnose someone with mild cognitive impairment, if the primary deficit is in memory, that's usually a clue to me that there could be an Alzheimer's disease picture that's in the very early stages. And this type of memory is different from the memory I talked about earlier. It's a different type of memory than memory loss than the type of memory that you've kind of learned over your lifetime. That's more semantic memory. This type of memory loss is remembering to take your medications at nighttime, or remembering times and events, or recent current events that you've read about in a newspaper or saw on television, et cetera. And this can be teased out from your history and from your cognitive testing. Remembering what items, on cue, if I asked you, what did you buy at the grocery store today? Remembering what were all those items that you bought when you went out shopping. So that's the type of memory that I'm talking about, less so the memory that you have accumulated, the semantic memory that you have accumulated over your life experiences. So we're going to talk about this later on, but the brain pathology is very complex, not fully understood, and researchers are working more and more to understand the pathology, and this will guide better treatments. But we're going to go over this as we talk about the current FDA-approved treatments. So diagnostic approach for diagnosing dementia in my clinic. You do not need to see a neurologist. Typically, a neurologist is not often needed, or a geriatrician. I worked as an internist. I was trained as an internist. We receive good basic background training in how to diagnose and treat, particularly Alzheimer's disease. This requires the whole office visit to be dedicated to getting your history, doing an assessment of your day-to-day function at home, doing a very thorough physical exam, including a neurological exam, tailored blood work. I don't always order imaging. Different physicians have different approaches. I'm not a neurologist by training. I don't always think a brain MRI is necessary. It may not change my management, but there are certain clues and certain concerns I have where I'm more likely to pursue brain imaging. I think neuropsychological testing can be incredibly helpful. I often rely on it. Let's say I'm having a hard time teasing out if there's a mood disorder contributing to cognitive impairment, or if there is an earlier presentation of disease, someone less than the age of 65, or if there is a more rare type of dementia. I think neuropsychological testing out in your community or at a Duke or UNC provider can be very, very helpful to the diagnosis. And sometimes I will say I work with a neurologist in our clinic who has done consultations even on my own patients. Patients with more of a rapidly progressive process or someone who is younger being diagnosed with dementia, oftentimes I will get a neurologist involved. So risk factors. So I think it's important to kind of touch base on our known risk factors. So age is the biggest risk factor. After age 65, the incidence of dementia increases significantly. Family history of dementia, especially first-degree relative or multiple family members who have an Alzheimer's disease picture, and there is a known genetic risk associated with dementia. Very important to talk about cardiovascular disease. If you've had a stroke or a heart attack, underlying heart disease, there's a higher risk for both an Alzheimer's disease and a vascular dementia. Really important to know, cardiovascular risk factors: smoking, high blood pressure, diabetes increase your risk. And then there's been a lot of information out in the media, and very important to talk about sensory deficits. What do I mean when I say that? Hearing loss that's untreated. There's a higher association with developing dementia. You want to make sure you're up to date on regular eye exams. Getting your hearing evaluated is so important. Medicare pays for this, right? And hopefully hearing aid cost is going to be decreasing now that you can buy them more over the counter. Head trauma. I think this is important to talk about. There's been a lot of information in the news about football players who've had repetitive head trauma who are at risk for developing a degenerative process in the brain called CTE, the chronic traumatic encephalopathy. And head trauma or traumatic brain injuries is a risk factor for developing cognitive impairment. So going on for protective factors, I cannot emphasize enough physical exercise. If you think about it, when you exercise, you are increasing your cardiac output from your heart, your volume that's even getting oxygenated and leaving your heart and going to your muscles, but also going to your brain. Exercise, exercise, exercise. That is the key in geriatrics for brain health, for your whole body health. I'm a huge believer in exercise. A healthy diet, I didn't put it up here, but it's so important, eating a balanced diet: fruits, vegetables, lean proteins, eating less of your processed foods, et cetera, is very important for brain health. Your mental and social activities. I cannot emphasize this enough. I have a 100-year-old patient with Parkinson's disease, 100 years old, still out in the retirement community playing an instrument and engaged in social activities and trying to keep up with physical exercise. That's amazing. This individual cognitively is actually doing quite well, some mild cognitive impairment, but I think those are really protective factors, and we cannot emphasize that enough. Learning new skills, right? Taking a class or learning a new skill is so important. There's also known that there's higher educational attainment or your type of career that you've had is important. And all of these factors contribute to a hypothesis, and that's talked about in that normal cognitive aging paper that I mentioned earlier, where it gives you cognitive reserve. So let's say you have a genetic risk for developing Alzheimer's disease, and maybe you have developed plaque in your brain, these abnormal proteins building up in your brain. It's thought that all of these protective factors can help give you reserve against decline or progression to dementia, even in the setting of pathological changes in your brain. So that's called that cognitive reserve, and it may delay the onset of developing a dementia. This slide is so important, so important. And it's ever more important because my patients are being flooded with information from marketing, and we'll talk about this in a minute, and about supplements and pills to improve your brain health. And I'm very wary of that. I want to focus on the basics, right? And this stuff is just so important for you. So prevention, talks about exercise, but also diets, as I mentioned, either not smoking or smoking cessation is so important for your brain. And then control of all your cardiovascular risk factors. If you have sleep apnea, so sleep disorder, treating that from a sleep specialist or with a CPAP machine is so important. Hearing aids, incredibly important. I had family members who never wanted to wear hearing aids, but I think they're actually much more stylish than they used to be. So important for keeping you engaged. And then, as I mentioned earlier, learning new skills, volunteering, being socially engaged is so important. So let's transition to talking about these supplements. And again, I'm not trying to be negative or condescending to supplements because I do think there's a place for some of them, but I'm wary of a lot of the brain health supplements. So this picture below, I just Googled. I actually went to Google and I typed in brain health supplements and I snipped this picture and put it in. And these are actually a lot of things that my patients come to me with. So I don't think Huperzine A is not up here, but Huperzine A I got a lot of questions about, individuals who've read about this supplement. And this is something that comes from a plant, I think it's a Chinese moss, that is manipulated in a lab. And apparently it's supposed to increase acetylcholine in your brain. Acetylcholine is a neurotransmitter that is important for memory, which we're going to talk about in a little bit. There's no data that, and this is not FDA approved, none of these supplements are FDA approved, that this actually improves or enhances brain health. Prevagen is the one here in the middle. Look at that cost, $110 for one bottle. That should make you a little concerned. But this, it comes from, I think it's a jellyfish, and it's a calcium binding protein, and they combine it with some vitamin D, and it's supposed to enhance brain health. Again, I get a lot of questions about vitamins. Vitamin E is one there's been a lot of studies about. It's an antioxidant, and inconclusive mixed studies about if it helps with brain health. Hormones, I get questions about estrogen or other forms of hormones. There is no proven data that hormones enhance cognitive health, and there can be risks with taking hormone therapy, especially later on in life. So again, just be wary. I would do your research, talk to your physician. Some people who have vitamin B12 deficiency, I put them on vitamin B12, so I'm not fully against supplements, but I just want you to be careful about them and talk to your doctor about them. So let's talk about pharmacological treatments. And we're going to start with the two that were FDA approved in the 90s and the 2000s, and then we'll transition from there talking about the newer ones, the monoclonal antibodies for Alzheimer's disease. So we're going to start by talking about the cholinesterase inhibitors and then the NMDA receptor antagonists. There's actually only one on the market that we're using. And these, go back. So the top two ones, important to know, they are not going to change the disease trajectory. If they're effective, they can maybe improve cognition by a couple points on some tests, or stabilize an individual from having, stabilize them and slow that cognitive and functional decline. And most of the studies on these agents did not extend follow-up beyond 6 to 12 months. So as a geriatrician, I'm actually wary of these medications being prescribed for years and years and years if we're seeing ongoing cognitive decline. Why am I still prescribing it? I used to do some of my clinical work. All my clinical work now is in the clinic, but I used to do some in a skilled nursing facility. And I had patients who had been on donepezil, we'll talk about in a moment, for years and years. And these individuals were, at the very end of the disease trajectory. And it made no sense to me why they were still on these medications. So again, shared decision making, but sometimes if they're not effective or a lot of side effects, it's really important to stop them. So in talking about pathology, I put up AD, saying Alzheimer's disease pathology, but these treatments are important to know are being used for vascular dementia. I'll talk about that a little bit more with regards to vascular dementia and the NMDA receptor, memantine or Namenda. But we're using them for Lewy body, dementia, et cetera, and other subtypes of dementia, primary progressive aphasia I'd mentioned earlier. So let's talk about acetylcholine. So this is neurotransmitter, and it's thought in Alzheimer's disease pathology that the neurons, this is that basic cell working unit in the brain that I showed you a picture of earlier, that in Alzheimer's disease you have more death of that type of neuron that produces acetylcholine. You have lower levels of this neurotransmitter in the brain, and this is important for memory. So what if we increase acetylcholine in the brain, right? So that's what the cholinesterase inhibitors do. Again, I talked about this, long-term effectiveness, not well known. So donepezil is Aricept, rivastigmine, and galantamine. These are our three. Donepezil was the first one that was FDA approved in 1997 for treatment of mild to moderate Alzheimer's disease. It blocks the action of an enzyme in the brain that breaks down that neurotransmitter. And it works to increase levels of acetylcholine in the brain. And with tests that were done, again, these were often 6 to 12-month follow-up. They were shown to see some improvement, usually a couple points on cognitive tests and cognition and stabilization, or maybe a little bit of improvement in day-to-day function. Big-time side effects that you need to be wary of. Nausea, diarrhea, and weight loss are the big ones that usually why I end up discontinuing that medication or this family of medications. You can also see some insomnia, difficulty sleeping at nighttime, maybe some hallucinations. Rarely, some people can get low heart rates and get symptomatic from that. And sometimes you start at a low dose, you try to up-titrate it. And if you have side effects or it's not effective and you're seeing progressive decline, it's important to stop it. Another interesting thing to note about these medications is if an individual is having more neuropsychiatric symptoms associated with Alzheimer's disease or another type of dementia, sometimes these medications can actually help and stabilize some of those symptoms. So before you reach to other medications that can have a lot of side effects, it's important to think about maybe a trial of one of these medications. So let's transition from there to talk about the NMDA receptor antagonist, memantine or Namenda. This was FDA approved in 2003. And how this works is glutamate is another neurotransmitter in the brain, and it activates this receptor, which is involved in learning and memory. But you can get excessive excitation of this receptor, and this medication can block that excessive excitation of that receptor, which is toxic to the brain. And it's approved for moderate to severe Alzheimer's disease. And there's some studies that think that it could be helpful for vascular dementia. So with vascular dementia, you are having low blood flow or low levels of oxygen in the brain, and it's thought that that can lead as well to excitation of this receptor, and Namenda could be helpful for vascular dementia. There's not good data that the cholinesterase inhibitors and increasing acetylcholine in the brain is helpful for vascular dementia. However, some people have an overlap, right? Alzheimer's and vascular process, and so you might end up trying to try one of the cholinesterase inhibitors for one of those individuals. A lot of side effects from this medication and why I often end up deprescribing it, which is an important term for geriatrics, is deprescribing medications. I can see a lot more occasionally anxiety, agitation, hallucinations, and so oftentimes I will end up stopping that medication as well, especially if it's not effective. So again, the key point, don't continue these medications indefinitely, and if you're having side effects, you need to think about stopping them. So let's transition to talk about The next part of this pathway, these abnormal proteins that I talked about earlier. What happens with Alzheimer's disease is you can have these beta amyloid proteins that are folding and congregating outside the neuron. I mentioned earlier that basic working unit cell of the brain. And these are thought to cause damage to the brain and toxicity and inflammation. And then there's another type of protein that's the tau protein that accumulates inside the neuron. And this forms that neurofibrillary tangle that was showed earlier on a slide. And that also is thought to cause inflammation and toxicity to the brain. So what if we remove the amyloid, right? Will we improve memory and thinking, right? That's a really good hypothesis and question that a lot of researchers asked. And so they came up, and I'm going to highlight some positive things first before I get into the controversies and the more negative aspect. So they came up with aducanumab, Aduhelm. It was FDA approved on the accelerated approval pathway in June of 2021. This is huge, right? This is the first drug in 2 decades, since 2003 really, that's been approved for the treatment for mild cognitive impairment or mild dementia due to Alzheimer's disease. That in itself, I will say, is very exciting, that there was something else that has been approved. And there were 2 phase 3 clinical trials, Engage and Emerge, which I put up here. And what this drug did well is it was able to remove plaque from the brain. They have MRIs that clearly showed that plaque removal. So structural, right? Structural improvement. However, they were stopped early because of lack of benefit. Although we were seeing structural removal of the amyloid plaques, we were not seeing certain benefits, right? We were not seeing, there were no proven benefits for memory and day-to-day function. And then there were a lot of risks involved. So 40% of the individuals in the high-dose aducanumab group compared to 10% in the placebo group had mild, but brain swelling and minor brain bleeding. A lot of these individuals were asymptomatic, but that's a large proportion of patients, and that is a concerning finding. Other negative aspects about this trial. So there were a lot of people who were excluded, older age, right, over age 85, but I have a lot of patients in their 80s and 90s who have dementia, right? It's not generalizable to my population of patients that I take care of in my clinic and that have dementia. And if you had vascular disease, if you had a stroke or a TIA, which is a lot of my patient population, you're excluded. If you're on a blood thinner, I have a lot of patients on blood thinners, a lot of patients with atrial fibrillation, right, who are on blood thinners, you're excluded. And then the other really, really concerning feature is that this was not an inclusive research study. It did not include people who were primarily, this was all Caucasian white individuals. They're not African Americans. There were not Latino Hispanic individuals. There were not other minorities included. This is not representative of our population. And this is very concerning. One of the individuals that Latorius and I work with, we were on a call maybe a week or 2 ago, and she put it really well. She said, y'all, this is bad science, right? If we're not studying how these drugs work in our entire population, this is bad science, especially since these diseases are disproportionately affecting these populations of individuals, and they're not being inclusive in their research. So we've got to do a much better job. In addition, the economic impact. Wow, something I really worry about as a geriatrician. Initially, when this drug came out, Biogen is the pharmaceutical company. I mean, $56,000 a year. That does not even include the cost of the infusions, right? An infusion, receiving the medication itself, infusion clinic to receive it, the MRIs. You have to get baseline MRIs and then multiple MRIs to monitor for the swelling or the bleeding that could occur as a risk factor. Enormous amount of money. Yes, they lowered the cost to $28,000 a year. Again, that's not going to be available to everyone, right? That's only going to be serving a select population of patients. And again, we have not seen clinical benefit in cognition and day-to-day function. So finally, the U.S. Centers for Medicare and Medicaid came out and said, we're not going to cover the cost of this drug outside of clinical trials. So yes, there are ongoing clinical trials. There is not one at UNC right now to receive this drug, and I'm very wary of it. I talk to my patients about it a lot. And I do focus on the positive. I think the hope and the message is there's a lot more research being done about Alzheimer's disease and related dementias, and we are learning more about the pathology and better factors or pathways to target treatments. So you're going to hear more probably soon. In January, I believe, of 2023, the FDA will come out with a decision about another monoclonal antibody. I think this was on the People's Pharmacy recently. I think I heard it on NPR one day. Lecanemab, so there's some information out there. It's another monoclonal antibody. It's going to bind to and clear amyloid plaques, so very similar to aducanumab. It's in a phase 3 study. And I think the important point here is that if you have Alzheimer's disease or related dementia and you are clearing the plaque, it may be too late, right? We actually think that individuals, before they are symptomatic with, let's say, Alzheimer's disease, years, potentially decades before, they may start to have this plaque buildup in the brain and these abnormal proteins. So maybe this plaque targeting treatment should start in earlier stages, right? Maybe it's too late. Or maybe we need new targets. But again, it's exciting because this is the first time in 2 decades that we have had a treatment come out for treatment of Alzheimer's disease. So I think the message and really the piece that I'm trying to drive home is there is hope in the pipeline. I really want to highlight that Latorius and I are working with a huge group of people. In September of 2021, Duke and UNC were approved by the NIH for an Alzheimer's disease research center. We're one of 33 across the country. There's one in Wake Forest, and then throughout the country, there's 33 centers. These are doing incredible work. We have people who are studying, to better understand the pathology of the disease and biological factors that contribute to disease so that we can better target our treatments. Our mission, our particular mission and focus at our Duke UNC Alzheimer's Disease Research Center is, reducing the burden of Alzheimer's disease and related dementias, but also a specific focus on building better inclusive research, reducing racial and ethnic disparities, and even urban and rural disparities that are associated with this disease. If you want to learn more about what we do, you can talk to us after the talk or go to our website here and learn about our work. And we are also, partnering with across the state with researchers. Wake Forest, Pembroke has great researchers, ECU, et cetera, through the North Carolina Registry for Brain Health. And you're welcome, more than welcome, to register. It's just a simple registry of information to receive information about prevention of dementia and clinical trials that are out there locally that if you are interested in participating in brain health research. I'll also take a point to just mention that it is so important within our communities, and we're excited to be here today to learn about prevention, right, of cognitive impairments and dementia, to advocate for brain health research within your community, and to get involved in brain health research or have family members, right? If you have a family history of dementia in your family, maybe your children or family members want to get involved as well. And we are a beautifully diverse state and country, and we really need to do a much better job, as our colleagues stated well, to improve our science, to have better science, and be much more inclusive for brain health research. So from there, I'm going to stop. I don't know if we're on time or maybe a little bit early, but here's our overview of things that I talked about today, and I'm happy to take questions now. Yes?
I have a specific question about the Dementia that was introduced in 2003. In your practice, have you seen the use of that increase combativeness and aggression to the patient?
Yes. So that's what I refer to as the... Oh, yes. So the question was, in my practice, have I seen Namenda, memantine, which is that NMDA receptor antagonist, worsen agitation, combativeness? Yes. So this is the primary reason why I stopped that medication. Agitation, hallucinations, aggression, that can happen. Yes. Correct. It's FDA approved for moderate to severe Alzheimer's disease and vascular dementia. I have seen a few patients, it's actually more my patients who have vascular dementia, who kind of stabilize on this medication. And I mentioned that earlier, that it's thought to have some neuroprotective effect against the low blood flow and hypoxia in the brain that can happen with vascular dementia. But it's been hard for me to tease out, even as a geriatrician, if it's the medication or if it's because I've done and the patient's done a better job of controlling those risk factors. So I'm hesitant about memantine. I do prescribe it, but I am very quick to stop that medication. Good question. Yes?
You talked about amyloid plaques and Alzheimer's. And the question is it a correlation or a causation? Is one causing the other, or they just happen to be there at the same time?
We're not sure. I mean, we do know from studies that if you are cognitively normal and you have plaque buildup, these abnormal proteins building up in your brain, you're much higher risk for developing particularly the Alzheimer's disease. But there are other things going on in the pathology of the brain that we have not fully sorted out. So I would not fully say that it's causing, right? It's not causing. We have not determined that clearing the plaques, even if you have them with mild cognitive impairment or Alzheimer's, is improving your memory and thinking and cognition. Good question. Yes?
Last year, there was a lot of push on finding a test for Alzheimer's.
Finding a pardon?
A clinical test for Alzheimer's, like blood swab, something like that. Whenever I inquired about that, they kept on telling me it is close to the research group and they don't know out yet. What's the situation now?
So your question is regarding an actual blood test or saliva DNA test for diagnosing. So Alzheimer's disease is a clinical diagnosis. We are doing work with figuring out tests that you can do that may help with the diagnosis, or that may tell you if you have a higher risk for developing Alzheimer's disease. For instance, a blood test, the APOE4 mutation. I don't even do that test in my clinic. I'm not sure. I don't even think it's covered by Medicare, but it's a clinical diagnosis. Yes, there's more work being done to try to find blood tests or that will help us with making a diagnosis, but it's a clinical diagnosis.
So you think you'll be able to do that confidently next year?
No, I don't think in a year. No, I don't. It's still a clinical diagnosis, right? That whole geriatric assessment, there may be a blood test coming out in the next couple of years that may help with knowing if you are more likely to develop an Alzheimer's disease or if you have a genetic risk factor, but we are not doing that in primary care geriatrics clinic. Neurology, I'm actually not sure. Latorius, you may know because you've worked with Andrea Bazzoki. Is she sending off APOE4 mutation tests, or you may not know? We are not in geriatrics and primary care. Yes?
Do you know the correlation for people who have both parents who have had dementia and their children?
So yes.
What does the research show their probability of getting Alzheimer's?
So I don't have an exact number for the probability, but significantly increased risk, especially for first-degree relatives or folks who are diagnosed with dementia, maybe earlier onset or even diagnosed in their 70s, where I'm much more clinically worried that an individual has a higher risk of developing dementia. And this is where the emphasis is on understanding the protective factors, right, and your cognitive reserve. Because you may have a really strong family history of Alzheimer's disease, but if you are exercising, good diet, controlling your cardiovascular risk factors, and some of those other protective factors, that cognitive reserve, I really do think delays the onset of the disease. And this is where some of our work is actually being done at the Duke UNC Alzheimer's Disease Research Center. We're trying to study people earlier on, in maybe even their 20s, 30s, 40s, early adulthood, who have a strong family history and kind of better understand those protective factors and biological factors that contribute to healthy brain aging and disease.
Then I'm just gonna ask one other question regarding that. How early should people who've had this in their family, this history, be evaluated?
So that's a really good question. If that individual has pretty good insight, and maybe they're starting to notice some subtle concerning things either at work in their day-to-day life, I would absolutely be evaluated. Dementia can present earlier on. You can see some types of Alzheimer's disease present, early 60s or 50s. It's important to know that U.S. Preventative Services Task Force, we don't recommend screening. There's not actually data to support that you should be screening everybody, especially early on, but it's something really important to talk to your physician about. And it's also important to note on that point that some individuals may come to me and say, I'm really worried, I've got a strong family history, something's off. Like I used to be able to do this complex accounting thing, maybe for my church or whatever, as volunteer work, and I'm having a harder time. And I do cognitive testing, and it's totally normal in my clinic. But the patient's concerned, strong family history, I'm more likely at that point, even earlier on, to refer out to neuropsychologists for much more in-depth testing. Good question.
One factor you didn't, or not factor,
Sure.
one issue you didn't mention, that women are more likely to have Alzheimer's disease than men. Do you know any reason for that? Theories or anything?
Yeah, that's a good question. I don't know the full numbers behind that. I think there is thought forgive me. Women are more likely to have Alzheimer's disease than men, or what's the theory behind that, or pathology behind that? I'm going to have to look more into that question for you and get back to you. It's possible with the pathways. As I had talked about hormones, there's been some studies with like estrogen and cognitive health, right? Estrogen's going to decline when you hit menopause. But there's also, again, inconclusive and no good data that hormone therapy and estrogen would decrease your risk for cognitive decline. Good question. Yes?
What about the recent headlines about statins decreasing?
Oh, really good question. So there's actually a study. The question was about headlines about statins decreasing probability for dementia. So there's actually a study at UNC called Preventable that one of my colleagues is working on with looking at statin therapy versus placebo and cognitive decline. So we'll have some more exciting research coming out from UNC. But it kind of makes sense in a way if you think about reducing vascular risk factors. So I have patients who have never had a stroke, have never had a mini stroke, and they have incidental findings on a CT scan. Maybe they had a fall and went to the emergency department. A CT scan shows severe plaque buildup in the small arteries of the brain, and that's a risk factor for dementia, and particularly vascular dementia. So it makes sense if you're lowering your cholesterol, right? You're improving maybe blood flow and supply and reducing your risk for developing plaque in the brain. So more to come. So think about Preventable. You can might be able to read about that research results soon. Dr. Kistler at UNC is highly involved in that study. Any other questions? Oh, yes. Sure.
All of us at this age most of us have children and grandchildren. And if you have a strong family history, am I hearing that the best thing is the preventative?
Yes, prevention, protective factors early on in life, exercise, diet, overall health, and getting involved in brain research, right? If you have a strong family history, getting your kids involved can be very helpful.
So it's senility, dementia is apparently caused by anesthesia, but I've heard now that there's no such thing. Correct, mother, aunt, and my husband. That's just pretty,
Yeah. I actually have a student who I'm working with who father has dementia, and this student has decided to pursue a degree with nurse practitioner, something to do that's learning a new skill and having a more, trying to do a protective factor, right, for brain health. And I think the protective factors we are not emphasizing enough. Not exercising and smoking have a really strong correlation to all types of dementia. So the cognitive reserve.
Press that kind of generation without feeling like you're being an act.
That's hard. It's super hard. But this is public health, right? This is, I come from a background of working in community health, and I always felt like we need more public health there. But getting our communities excited about, brain health protection is super important. Yes, it can sound like nagging. No, that's okay. That's okay. But talking to your kids about being involved in brain health research to learn more, I think is a really great way to start, especially if you have strong family history. We need people in their 20s, 30s, 40s, 50s, et cetera, to be involved early, to study their brain, especially with a strong family history. What are other biological factors contributing to dementia other than the ones that we have talked about today? Yes.
So, there's, since amyloid plaques and tau channels are, let me ask you a question, sorry. There's been some controversy about, work that's been used for Alzheimer's research that's been called into question.
Mm-hmm.
And could you comment about that?
So you're talking about specifically the proteins. Yeah, so it's highly controversial, and I had mentioned this earlier in the slides. This was not an inclusive population that we have been studying, particularly Aduhelm was studied in a majority Caucasian white population. But is the pathology different if you look at different individuals? If you have African American background, a Latino Hispanic background, Asian background, et cetera, the biology may be different. That's extremely controversial. That is bad science. If you're just studying this medication and these pathways in that type of patient population. So yes, and it was also controversial that, there were a lot of other folks who were excluded from that trial, but I think that's the answer to your question. Yes. Another question.
Do you think they were purposely excluded, or I've just heard it's very difficult to get people in the trials?
So the answer that one of my colleagues would say that has done research in improving inclusion in brain health research is we have done a bad job as researchers getting into our communities, building respect, getting to know our communities, serving our communities, and recruit. So the onus is on us in the academic research institutions. I wouldn't say it's hard. I would say you just need to be out there in the community and talk to people. And that's what particularly my colleague Latorius is amazing at, having a background and even working out in Harnett County, which I have learned about her. But so the onus is on us.
The old term hardening of the artery.
Oh, yeah.
That's what I heard, not that I have a
Yeah.
lot of it in my,
Yeah.
but is that where the vascular?
Yes. So hardening of the arteries, yes, that's a term meaning plaque buildup in arteries. And you may not know, right? You may tell your provider, your physician, I've never had a heart attack. I've never had a stroke. But if you have a lot of the other risk factors, high blood pressure, diabetes, smoking, you are much more likely to have plaque buildup that's you may not even know about it, even in the blood vessels of the brain, which is what I was talking about. The common term that you'll actually hear physicians say is small vessel ischemic changes. You'll see that on CT scans and MRI scans, and that's just kind of plaque buildup. Or calcium deposition can also occur. Uremic poisoning. So
My grandfather, well, that was Butler, but we were always told it was uremic poisoning.
So, yeah, so uremia is something that can happen with kidney failure, and it leads to cognitive decline. It does not cause a neurodegenerative process, but it causes something can cause encephalopathy, and this is more of a different type of process, but yes, it can cause cognitive decline, especially at the end stages if someone needs to be on dialysis before they start dialysis, or if they're dying from kidney failure. Yes. Yeah, really great question. What is the UNC Duke program doing for the caregiver? So one of our colleagues, Bobby Matchtar, is head of the Duke Dementia Family Support Program. Wonderful program for the patient and the caregiver. Amazing support. I tell all of my patients and caregivers who are being diagnosed with dementia about this program. I guess, bragging a little bit about my care manager, social worker, but our geriatrics specialty clinic, we're called a specialty clinic, not just because we have a geriatrician, a psychiatrist, and a neurologist involved, but our social worker is probably the best I've ever seen, and I've worked in a lot of different places in my training. So incredible support for families that we can provide. Another name I'll just throw out there, but it's a great name to know about for family support, and she's from North Carolina, but it's Teepa Snow, who's an occupational therapist. I even watched her videos when I started my geriatrics training that helped me learn how to approach an individual who has dementia. So when I worked in a skilled nursing facility, it trained me in how I talk to and approach and engage with someone who has dementia. Great resource. But yeah, check out the Duke Dementia Family Support Program. I don't have the link up here, but it's a wonderful program. And I'll have more information about that online on our next newsletter too. Yeah, great questions. Yes.
So since most research tends to be reductionist, like taking an area of interest and narrowing it down to a specific small component part, and that's not been effective at finding treatments for Alzheimer's, hugely not effective. Like what, 240 or 250 failed treatment
Sure.
trials and so on. So would it not be time for a different paradigm, for looking at a more holistic approach than looking at individual component parts?
So you mean a holistic approach? I guess I'm trying to understand your question. Of treating a patient, a holistic approach of treating someone with dementia?
Yes, but I'm talking about more about, in research, trying to learn more about Alzheimer's, to look at
The brain, to learn.
multifactorial approach, instead of trying to find italic letter Q that's responsible.
Sure. So the question is, rather than focusing research and treatments on one biological target, looking at the brain as a whole to better understand it observational trials, population trials, and better understanding the brain. And yes, I would say that there is a focus on better understanding of the brain and how it works with just normal aging. Yes.
In your slide 23, you're talking about the amyloid plaque being removed by these two drugs engaged in tumors.
Yes.
When that happens, does the memory or cognition come back?
So the short answer is no, there was no clinical benefit that removing those plaques actually clinically improved cognition and function.
What that means is even if it may reduce the plaque, it may not cure it.
So for right now, uncertain clinical benefit from those drugs that were studied in individuals who had mild cognitive impairment or early stages of dementia from Alzheimer's disease. And so I think that's the point trying to highlight home, is that it may be too late. Once the plaque is already built up and you have signs of dementia or Alzheimer's disease, clearing it may not do anything. So maybe targeting some of those, clearing the proteins earlier on in life before you become symptomatic, or again, thinking about different pathways to target.
So removal of the plaque may not be the solution at all.
Exactly. It may not be the solution at all, but it's exciting because it was something new and we're learning more. But there's ongoing clinical trials with aducanumab or Aduhelm to help us better answer those questions. Great. That may be all. Thank you. You all are so engaged. Thank you so much. Thank you for this time.
Thank you so much. Next up, we're going to take a short break in a few moments, but we'd like our vendors to come up. We have several vendors here today that are going to give a quick blurb on what they offer. So if you guys wouldn't mind coming up and introducing yourself and what company you're representing, as well as what your company offers.
Good morning. My name's Marcia Jarrell. I'm the Executive Director at Sarah Care Adult Daycare Center, and we specialize in caring for people with dementia, the whole umbrella of dementia, as well as Parkinson's disease, strokes, and things of that nature. We really work at engaging people in social programs and activities that are appropriate for people with dementia. We set people up for successes. A lot of folks that have dementia hear what they can't do, and we look to focus on what people can do and provide a meaningful day for them. I love what Dr. Tiller talked about in terms of prevention, physical exercise, activities, and mental programs. That's all what we do with folks with dementia, and I can tell you that talking to families over the years, we've been able to not erase the changes in people's brains, but we can kind of raise some of the fog each day and give people a meaningful outing for the day. So thank you for being here.
I'm Amy Hickey. I'm with Legacy Therapy. We are here on site. We do physical therapy, occupational therapy, and speech therapy. And, the orders are written by a physician. Speech therapy actually works with cognition. So we're here if you need anything. Our goal of being on campus is to help you age in place, both with physical needs and impairment as well. So that's it.
Hi, I'm Tamara DeMello. I'm from Silver Linings. We do mental health counseling. We are not in the building, but we can come to you either in your home, or we can also we also give therapy in our office in Cary, as well as teletherapy. Now, before COVID, we strictly saw seniors. They're our specialty, and they're still very close to our heart. But when COVID came and we started teletherapy, we decided that we were going to help anybody 21 years or older because the need was so great at that time. Now, we see people for a variety of things. It can be adjustment issues. It can be issues with grief or loss. It can be marital issues, family issues. Just discussing things with your kids is a little tough sometimes. Sometimes it can be a short-term thing, very short-term, a couple sessions. Sometimes it can go on longer. It just depends on what the need is. We also see people with bipolar and schizophrenia, a variety of things. The only thing we don't do is if you're in a crisis, for example, if you're suicidal, we are not the people to call. You would need to call 911 and get immediate help with that, or a crisis line. Another exciting thing about us is that we do take insurance, including Medicare, which is exciting because a lot of mental health professionals do not do that. So we have literature over there if you're interested at all. I'd be very happy to answer any questions and help in any way that we can. Thank you.
Good morning. I'm Latorius Adams. I'm a colleague of Dr. Tiller, who spoke with you this morning. I am here representing the North Carolina Registry for Brain Health. That is an email registry that you can sign up for today. It's information about getting informed and being involved in research studies. Even if you don't want to get involved in a research study, you'll get the latest research, tips, and news about Alzheimer's and other related dementias that is going on at UNC Chapel Hill, Duke University, Wake Forest, and ECU. So a way to stay informed and be involved is to sign up for the Brain Registry today. Come by the table, and I also have other great information about brain health. Thank you.
I'm Rachel Strauss. I'm Rachel Strauss, and I'm a volunteer with Dementia Alliance of North Carolina. And probably now you're wondering, am I normal? Are you normal? Oh, God, I can't see you. My glasses. I've got to remember, where did I put them? Oh, I was reading over there. So let me go check and see if they're over there. And I don't have dementia because I could backtrack and see where I left my glasses. So when you go into a room and you go, well, where are my keys? Well, I got out of the car today, so I don't have a pocketbook. Oh, yeah. My keys are in my pocket because I can think, and I know what they're for, too. So don't worry about it. I mean, I know she's told you a lot of things, but think about, can you think and remember why you did it, or what you needed to do? And by the way, no two Alzheimer's are alike. I mean, no three Alzheimer's are alike. Now, if I had Alzheimer's, this is Billy. Billy's my child. It's not a doll. It's my baby. So if I give my baby, would you hold her or him? Hold Billy. Hold Billy for a while. And today is what? What day is today? Oh, it's Thursday. Okay, thank you. So if I have Alzheimer's, and wait a minute, where are my keys? Do you remember where they are? No, someone told me they were in the freezer. Let me go look in the freezer, and sure enough, there are the keys. But what do I use the keys for? Why do I need them? I'll just put them back in the freezer if that's where they belong. With Alzheimer's, you get to the point, it's gradual, where you don't really remember where things are and what to do with them. And what's today?
I don't know.
Oh, well, I don't either. Do you know what day is today? Thursday. Now, I may ask you, wait a minute, what day did you say it was?
It's always Thursday.
It's Thursday, because I look on the calendar, and every day is a different day. How do I know which day is Thursday? So it gets really difficult. Are you done with my baby? Sarah. Is this Sarah?
This is Billy.
Is that my baby? Okay. So again, going back in time, sometimes your memory, you remember things a long time ago, and sometimes it's the more current things like, did I take my medicine today? But there's so many clues that can help you. Yeah, I have to keep a to-do list, and I love to check it off. But that doesn't mean I have a memory problem. I've learned how to deal with what do I do today, okay? So there are a lot of clues that you can use if you, and by the way, not that you have to have Billy, you can also have a dog or something. But you can do that. But let me remind you that no two Alzheimer's are alike. So what does Dementia Alliance of North Carolina do? We are a nonprofit. It's free. And when you call up, it's probably that you have a loved one that's just been diagnosed or you're up to your head in dealing with someone that keeps asking, what day is today? And you cannot deal with it anymore. So we help you understand that. We go out and do resources, fairs like this to talk about it. One of the things we have, and Duke has a great one as well, is we have a whole list of support groups. And those support groups are where people get together and we talk about our problems. He won't bathe. He stinks, and he won't get into the shower. He won't go wash his clothes. He won't do this. We talk about, and God, incontinence. He wants to wear regular pants. He doesn't want to wear Depends. What do you do with this? So as in a support group, you're basically talking about the problems or issues that your loved one has and how you're dealing with it and how they're dealing with it. Of course, you know it's snowing outside. Am I right? Yeah. You remember what you did in the snow? Yeah. So you don't have to argue with them. If they think it's snowing, it's snowing. Who cares? You know, don't you get too upset. So we deal with, in a support group, talking among others and seeing, do we have similar issues? Because, again, no two dementias are alike. Even though every kind of dementia does have unique characteristics about them. At my table, you can come get anything you want about dementia, about caregiving, or about how to deal with these things. But Dementia Alliance is here. It's down the street. We also have memory cafes, which we used to have right across the street, where you can bring your loved one with you and enjoy dinner and entertainment. Because music is one of the last things to go, so they love to sing. And I can't believe they remember all the words that I've forgotten. So that's Dementia Alliance of North Carolina.
Thank you. All right, it's time for prizes. Dr. Tiller, could you pick a number between 1 and 50? 35. So look on those PowerPoint slides that we had on the chairs in the top right corner. Oh, okay, pick a new number. 11. Woo! Get a Food Lion gift card. You can go shopping. All right, one more number. 27. All right. Do you like pink? This is from Dementia Alliance. And who gave the Food Lion gift card? Legacy did. Thank you. All right. That we're going to do more prizes again. Yes. So stick around, but you do get to have a break now. Move, get up slowly, get your balance, pump those ankles and feet before you get up. Bathrooms behind you. We still have coffee, fruit, blueberry, zucchini bread, and quiche that you can come enjoy. And then come back in 15 minutes, and we will get our panel started. And then, of course, visit our wonderful vendors. Let's give another hand for Dr. Tiller. All right, so get up slowly, take a break, and come back. All right, we're going to get these doors, and we're going to get started with our panel of lovely ladies.
right, most of you might know some of our faces, but you may not. So we'll do a quick intro of who we are, and then we're each going to talk for just a few moments, and then hopefully open the floor for some questions and discussion. So I am Carrie Ritchie. I am your Health and Fitness Director. I've been here, December 1st will be 13 years. Yes.
Hello, I am Dr. Haley Webster. I am the pharmacy consultant with Medipack Pharmacy. We provide all the services for meds in the health center. I have been with Medipack about 3 years now, actually. Yeah.
I am Joanna Bell. I am a registered dietitian. I do work with Sodexo. I've been here at Springmore for 23 years. So I am, as I said, a registered dietitian, but I'm also a certified specialist in gerontological nutrition.
My name is Leah Newton. I am a speech-language pathologist. I have been a therapist for 15 years. I've been here at Legacy. This is my 3rd year. And I do specialize in dementia management for the Springmore population.
All right, so I guess I'll kick it off. I said I wanted to go last, but I'll go first. Well, Dr. Tiller already said it. So, of course, my piece is exercise. So I love when doctors say it because it just means a lot coming from a physician. So obviously that's my passion. That's why I'm here. That's my job. But part of my job is to encourage you all. So most of you here already do it, which is wonderful. Keep doing it. But hopefully you can encourage your friends and your neighbors and your family. So since you already know that we all need to exercise and that it benefits our heart, our brain, everything, I thought I would just focus on the recommendations in case you don't remember or haven't learned what the typical guidelines are. So if you Google it or look anywhere on the internet, you will find these numbers. Now, these numbers aren't the end-all, be-all. But with the Department of Health and Human Services, there's a wonderful book, and I'll make sure we have a copy in the library. If you do want to read more, you can. Does anybody know what the minimum or the target number of minutes is that we should aim for each week of cardiovascular? Raise your hand. 150. Ding, ding, ding. I should give you a prize. Yes, 150 minutes of moderate aerobic activity. So whether that's walking, using an exercise machine, swimming, gardening, getting up and down, it does not have to be all 30-minute, people say 5 30-minute sessions. It's a nice way to put it, but it does not have to be that way. Now, you may have some friends or neighbors that say, I cannot do 150, so that's okay. You encourage them to do what they can. If there's arthritis or other injuries or other health conditions, that 150 may not be attainable. So you do what you can, and then you gradually increase when possible. So of course, you should always ask your doctor or therapist if you're just starting a new program or if you've had an event or a surgery or injury or fall. Always make sure that you are doing something safe and something appropriate for you. And then once you talk to your clinical people, then you can come to us and we can help you. But we will gladly tell you, you need to go see your doctor first before you start working with us. So just want to encourage you with those numbers. The other thing that I always like to remind people, living here, of course you get to walk a lot. I know you have to walk to get your mail and go to the dining room, and for some of you, you live, down at the end of a hall, and it is a bit of a walk. And so sometimes people tell me, well, I do that walk 2 or 3 times a day. That's my exercise. Well, they don't usually like my answer. I say, yes, that's good, but that's not enough. Especially if you're starting to have some trouble. If you're getting a little more winded or you're feeling a little weaker, if you only do those 2 trips every day and that's it, you're going to keep declining. So that's why we always have to carefully challenge ourselves. And I remember from another therapy discussion with Legacy, energy conservation. So that, again, it doesn't mean you have to do all 30 minutes and wear yourself out and now you can't function the rest of the day, but do a 5-minute walk here. Or if you like to do puzzles or watch TV, get up on those commercial breaks and don't sit for hours on end. Sitting, I'm sure you've heard the phrase, sitting is the new smoking, especially with the pandemic and a lot more isolation and sitting. You just got to move. Move, move, move. Yes. Yes, sorry. Okay. CJ. Sorry. I was going to say you guys can continue in the hallway. It's okay. All right. We'll do questions at the end, so I'm going to pass it on to Haley.
So when I look at meds, because that is my major role, when you get to me, normally the provider has already started you on medications that may be needed for dementia or to help keep your daily function. I think Dr. Tiller spoke about some of those of Aricept and memantine. But a point that people always kind of forget is looking at what you have been taking and deprescribing. We live in a society kind of now of we're going to take a med to fix something, or you'll go to one person, one provider, and another provider, and they don't speak and either have duplication of therapy or you're on too much medications. So that is the big push right now in the pharmaceutical world is, yes, we're looking for new medications that can help conserve your daily function, because that's the goal right now of therapy when you are looking at that. It's not to reverse necessarily your cognitive function, but to preserve what you have and ensure that you can continue your daily function to get the best out of life. I mean, we all want to be able to continue our daily activities and be able to go out and eat with friends, be able to go exercise, enjoy our daily lives. So a lot of times when people come and I look at their meds, they don't realize that some of the medications they take daily are actually affecting their cognitive function. So a lot of people, especially during allergy seasons, we love our Claritin, we love our Zyrtec, but not necessarily long-term should those necessarily be continued, because those are an example. We all like our NSAIDs, your naproxen, your ibuprofen. Those long-term can also lead to daily decline. So that is kind of what my role is in the health center when you come, and even if you're there for short-term rehab, I look at your meds and I'm like, okay, I see they're on a multivitamin, that's good, or if you need one, I'll ask you that. Some people come in and they have quite a few extra medications. Simpler is better. Yes, you need to have your medications to treat your hypertension, your diabetes, and make sure that's under control, because with those being controlled, it also helps with your cognitive function. Stopping it from declining as rapidly is the thought process. Again, it's different per person, and everybody is different. Every case is case specific. So I have to look at everybody on per case, just because everybody has different goals. Everybody has different lifestyles that they want to achieve. So that's kind of the big push for me is evaluating the person and their meds. And I work with the providers because there are medications that can help to keep your daily function, like the donepezil and the memantine that I think was spoke about. But I also look at the whole of all the other meds to make sure there's nothing else that can be helping with that decline or causing that.
So I spend the majority of my time working in the health center, and I did want to share a quote that comes from the Alzheimer's Association. That's one of my favorite quotes. A healthy diet is only as good as the food that is eaten. So a lot of times what I am seeing is people won't eat. And families and loved ones get concerned. Oh, mom used to always eat all her vegetables, or she loves salads. And at that point, I'm not as concerned with getting a balanced diet. We want you eating. So sometimes we may have to sneak, some fruits and vegetables in, but, if you like a sandwich every day, that's what I'm going to have someone eat. We're looking to serve familiar foods, things that are simple and less confusing. So taking away lots of condiments that might be sitting on the table that get distracting when someone's trying to eat. Serving foods one at a time instead of serving your salad, your entree, your soup all at the same time, where someone would have to decide on what do I do. So we try to make that as simple as possible. Even putting just a simple tablecloth on the table, something not patterned, just a plain white tablecloth, and then having a plate that's a different color. Actually, it's shown to increase someone's intake. So maybe you have a white tablecloth and a red plate. That might help with intake. But I definitely encourage loved ones not to worry so much about what the person's eating. You just want to continue to have them eat and make mealtime more pleasurable. So if you're both worrying about what the one person is eating, it's stressful for the caregiver as well as the person you're caring for. So my main message is make it simple, foods you enjoy, so you both can have a pleasurable mealtime experience.
Again, I'm Leah. I am the speech pathologist here at Springmore. And one of the things that Legacy has implemented here at Springmore is our dementia care program. And it does include all therapies, not just speech language pathology, but also physical and occupational therapies. Our goal is to keep you in your, not you per se, but everyone in the community in their least restrictive environment. So if you're able to stay in your private residence, that is our goal. So we want to implement, if you or a loved one is suffering from dementia or memory loss, to possibly implement strategies to keep you safe in your home, whether it be a caregiver, like private duty caregivers, Springmore caregivers. Occupational therapy can assist with improving your ability to complete your activities of daily living, so your dressing, your bathing, that type of cooking, those types of things. And what I do and focus on most is implementing compensatory strategies for people to keep them in their homes. So whether that be visual aids to assist them in remembering their appointments or remembering names and that type of thing. And some people don't necessarily have dementia, don't have a diagnosis of dementia, but they're noticing they're having some difficulty with short-term memory, or they may even be having, so let me go back. So my title, speech language pathologist, is sometimes confusing because people think, well, I talk fine. There's nothing wrong with my speech, but speech pathologists address anything from the neck up. So if your voice, swallowing, if someone has suffered a stroke, they could possibly have swallowing impairments, Parkinson's disease, MS. But going back to dementia, I implement strategies in order for you to basically stay in your home. Hopefully, a lot of times, kind of piggybacking on what Joanna said, sometimes we find that residents are not consuming enough food or liquids. They're not drinking enough water. Dehydration can cause brain fog. It can cause confusion. So you may think, oh no, do I have dementia? Not necessarily. You just may be dehydrated or malnourished. So we look at the whole person, what you're dealing with as far as your medical issues, how's your nutrition and that kind of thing, and we formulate an individualized plan to address whatever your needs are.
We'll open it up for questions. She had her hand up first.
My husband needs a break from me. Because he's, he's afraid to leave me, but I'm fine. But what do? I don't know if I'm safe by myself, but I think I am. Am I?
I
think that would be a good conversation or appointment with a social worker or a chaplain, and to have those conversations or with your doctor. And then there are resources available, home care aides and things like that, to help when needed. So,
Can you repeat the questions?
yes, she was wondering if she wants her husband to be able to go out and not worry about her being home alone. Yes. Betty.
I have a question for you. Yes. With regard to looking at the drugs that a person takes, is that provided only for those in the health center and in supportive living, or is that assessment, one-time assessment of the drug issue open to other residents?
So her question was that comprehensive med review, is that only for the health center or supportive living individuals, or is that available to everywhere? So as of right now, for my position, it is only for the health center, but that is something that if you want to speak with your PCP or one of your, whoever you go to visit, I'm sure they will gladly look at that and see if there's any excessive meds, if you're concerned about that. It's a big push in the medical field to decrease meds. I mean, who wants to take 15 meds a day? Or how, I mean, less is definitely the goal. So I'm sure that is something they would gladly look at for you.
And to add on top of that, also for fall prevention, very important to make sure your doctor or the clinic, somebody knows all the meds you're on, because those can have interactions and cause dizziness and other side effects that could lead to a problematic fall. We have done events in the past with other pharmacies. We used to call them the brown bag events, where you could bring all your medications for review. So maybe that is something we could look into again. Any other questions? George?
I don't seem to get thirsty, and I'm aware of the need for water and so forth. This is, for me, I think, thinking back on it, I think it's been true throughout my life, but there's one rule of thumb that I used to think was work, the color of your urine, for example. Is that still something, I mean, that's a simple thing that if it's valid, I think it's still valid, and that you can sort of use that as a guideline, but the only thing I can think to do is try to force myself. I always drink a glass of water at lunch, for example, because they put it there, but I don't think about it till the end. I think it'd be better to drink at the beginning of the meal, and you prevents overeating sometimes to drink first rather than at the end. So I don't know if you have any. I mean, I think there must be a huge variation individually between the people's need for water or something, because I think I'm on the low end, obviously.
So to briefly summarize, and then you can answer.
Okay.
George was asking about thirst and hydration. He doesn't get thirsty very much. So one, you can address that. And then just strategies for helping with hydration.
So the first question, our sense of thirst, actually, our ability to feel thirsty decreases as we get older. So you're less likely, they say if you're feeling thirsty, you're probably already dehydrated because you haven't had enough to drink. He was also asking, is the color of your urine a good way to measure if you're hydrated or not? And yes, that still is a good way. So if your urine is very dark yellow, that means you're not getting enough. You want it very light yellow. So that's definitely a very easy way to look to see if you're getting enough fluid. The amount of fluid varies for each person based on your body weight as well as any medical conditions. Some heart conditions, you do take less fluid in. So that would be something to discuss with the doctor, or you could ask me as well. We could calculate that amount out. But my best recommendation is know how much water you need, and maybe just even have a pitcher on your counter. Fill it up every day and know by the end of the day that you need to drink all of that water.
What I have found is having this. It's 24 ounces. I drink 2 of them before afternoon, and then I don't worry about consumption. This gives me a way of knowing whether I'm drinking enough or not.
Absolutely. So she was saying she has a water bottle that helps her keep up with how much she's drinking. And it's such a good visual because we kind of just forget. We get it going about our day and don't really drink. And, oh, I'm not thirsty. I'm just going to keep going. But if you have that visual reminder sitting there, you're more likely to drink. And it doesn't have to be water. I know lots of people just don't like water. So other fluids count. So if you're drinking milk, if you're drinking juice, even tea, some of the things that have caffeine that we used to think of more as a diuretic, those still count as your fluid too. So just keep drinking and just be mindful of how much you're taking in.
That also can lead to risk for falls. I know this is a dementia conference, but we all know that falls are a very big thing around here. You may have fallen, you may know somebody who has fallen. So please stay hydrated because you can get weak, confused, and we've seen people go to the hospital just from dehydration. So very, very important. Other questions?
You were saying something about taking allergy medications on an ongoing basis. I'm somebody who suffers from it ever since I moved out of my home state. I've taken shots. I did that for 10 years, got up to the level that I could reach, and then they cut me loose. And still, I'm finding the need to use a steroid spray and either Claritin or Allegra, one of those, on a daily basis. What is there for somebody like me?
So this is one of those case-by-case kind of situations where you look at some people just continue it just because they started on it and just don't stop it. But for you, that would be when you come and speak with me, we'd have a conversation of, is it worth continuing this medication, or are you okay with having those allergy symptoms? That's kind of where it gets to at a certain point of what are your goals? Like, if we could try to stop it and see if you're having confusion, dizziness, or have recently had a fall, if by stopping that clears those symptoms, well, then we can decide, do you want to have allergy symptoms, or is it worth having your confusion decreased, if that makes any sense? So it's all, you have your goals of what your therapy you want from everything. So that's kind of why I have to look holistically at a patient to see what are our goals and what do you want to achieve.
I don't understand the confusion part about taking these medicines.
So some of the side effects of some medications can cause that, and it's just how they work in the body and how they affect, and that's what can cause this increased confusion, and it's just how they work within the body.
I've been taking Zyrtec for 20 years, and I'm beginning to question whether I should be doing
Well, no, that was just an example. Like, that's just for some people, it affects them more than others. It's just how your body, that's the one thing, everybody is very individualized. If it's working for you, or if you see, that would be one of my first ones that I would try if you came to me and said, I'm confused, I'm falling, or I'm forgetting to go somewhere. And if you're not, then you're fine. But it's just when I look and we're having these certain symptoms, that's what stuff I look at. I'm not saying to stop.
If I'm not confused and I'm not falling and all that stuff,
You're good to go. You're good.
then I don't want to take it if I don't have to. So,
I mean, you could do a trial of.
trial of quitting, like, have you tried that? It doesn't work?
I'm allergic to everything, though. So,
Yeah. I mean, if you didn't think you could do a trial, and if you do have symptoms again, you'll be fine to restart. Yeah. No, that's not with all your medicines. Don't do that with all your, don't just randomly stop taking some of your medicines. Just please do not do that. No, please don't do that.
Excuse me, I have a comment about this, and that is that you wash your hands and your hands look dirty or whatever, and things are bugging you. Or if you get something in your eye, you may put an eye drop in. Don't forget that simple saline nose sprays are going to dilute any allergens that you're getting if they're coming in by your nose. And so just having air or ocean or any of those work very well just to go wash your nose out with it. All it takes is just 2 or 3 sprays periodically, and the chances are you won't get too much sodium. And I think relative to antihistamines, you want to be sure you're in the second group of antihistamines, not the older ones, Benadryl
Right.
or Trimeton.
Yep.
Those have much more side effects in terms of drying.
Agreed.
And in terms of really slowing you down in terms of fall possibilities.
There you go. Great.
Other questions? Peg.
For the speech and language say it. They understand what's going on, what you've asked or talked about. And then they get mad because they can't find the word they want to use. Do you have anything you can recommend to caregivers as to how to deal with that? So I know my sister doesn't want you to jump in and fill in the word for her, but what can you tell a person to do to make it a little easier when they can't find the word?
So, did everyone hear her question? Okay, so if they're having an expressive aphasia, is what we call it, difficulty retrieving a word, there are several strategies that can be implemented to hopefully help the person find the word. Depending upon how severe the aphasia is, it may or may not help. But if you want, I can print you off a guide with different strategies that they can use to hopefully help find the word. But to your question, yes, there are some strategies that can be implemented. And I'll make sure I find you afterwards, and I'll get your information so that I can give you that, okay? You're welcome. Oh, sure, of course. I know.
How about we make copies and put them in the Wellness Center?
Yeah, I'll make sure I get those to Carrie, and then you all can, yeah. That's a strategy. That is a compensatory strategy. Any more questions for me?
I do. I'm going to read this. So we did have one thing submitted. It says, have you heard the acronym coined by Harvard researcher Rudy Tanzi describing lifestyle and behavioral strategies that are associated with reduced risk of Alzheimer's disease? They use the acronym SHIELD: sleep, handle stress, interaction, exercise, learn new things, and diet. Do you think it is appropriate for someone who is at risk of Alzheimer's disease to choose the SHIELD behaviors to help reduce his or her risk? Yes. I think Dr. Tiller also really emphasized those protective factors. I would also say try not to get fixated or stressed over doing all the right things, because then you're counteracting what you're trying to accomplish. Everybody has their own interests, their own values, their own belief systems, so you got to kind of, like she said, look at the goal, look at the whole person, think about what you want out of your life here at Springmore, and think about what you want to do. And you have so many resources available to you, all these people sitting here, the clinic, the social workers, the chaplains. So if you don't know what to do, or you feel stuck, or you need an idea, or you have a question, reach out so we can help you. And you also have your community of residents to live life together and to do some of these things together, or to talk to each other for ideas. You know, I'm struggling with this. What do you do, or what's worked for you? So yes, those are all wonderful things to think about, to do the best we can, but not to get so stressed about it would be my personal opinion. Anybody want to add anything? Any other questions, comments from residents, staff, anybody? Who wants a prize? All right, Betty, I told you you'd get a prize. Do you or Blake like Dairy Queen? That's for getting the question correct earlier. All right, and we have this lovely gift basket put together by marketing, by Springmore Marketing. Charlotte, pick a number between 1 and 50. 18. Does anybody still have their packet? Remember their number? We might have to pick another number. Pick a higher number. Oh, you have 18? Let me see, Dick. Woohoo! So that concludes our, we do, where? Oh, the pumpkin is the gift. Oh, beautiful. Can we take it? Just kidding. All right, Allison, pick a number. 34. That was back there. Ellen. I'm slightly jealous of your. I'll set it right here on this chair for you. Okay, thank you. Did you make that? No. All right, now that, any more prizes? All right. So thank you for coming today. I hope you found it helpful or beneficial or got something out of it today. Some of the vendors are still here, so feel free to stop by there, chat with us up here. We have till 12, then we have to clean up. So you're allowed to chat for a little while. Have a wonderful day. Thank you for coming.